What's up, everybody? How are y'all? Good evening. Hope everybody's had a great day. Gonna start on time because again, this is going to be a super long class. It is what it is. It's part of patient assessment and diving off into the new medical part. It is just, it's tough. It's hard. It's a lot of information. Is the best I can tell you guys. Some of the things I'd like to go forward to is just make sure you ask questions. Make sure we kind of get the information out what you guys are looking for. Please don't wait to the last minute to ask questions because there's a lot of chapters, a lot more left in this particular chapter for us to cover tonight. So let's get started. We're going to dive right off into it tonight. So determine the priority of a patient. So what I want us to figure out is high priority patients include those of any following conditions. We want to make sure if they're unresponsive, have difficulty breathing or uncontrolled breathing, they are a high priority patient. Our high priority patients are the ones that we're going to be like lights and sirens on the way to the hospital. We're going to treat them as trauma patients. And I say trauma patients because everything is done on a different scale. When we say that, it's like we're going to reassess them every 5 minutes. We're going to have more a tendency to pay attention, to keep eyes on them. We're going to keep repeating over and over and over. Anything that has vehicle crash involving death of a passenger, ejection from a vehicle, a rollover, a high-speed crash. At the same time, let's include motorcycles into that because we know that the mechanism of injury is going to be high in any motorcycle collision. Vehicle versus pedestrian. Again, we know that there's going to be a high issue for injuries there, and fall of 15 feet or 3 times the patient's height, because anytime 3 times the height is about 90% fatal. So we have to be cautious in understanding what the potential underlying issues are with them or underlying injuries. So altered level of consciousness, severe chest pain, pale skin or other signs of perfusion, complicated childbirth, severe pain in any area of the body. Now, remember, even though moving through EMS world and diving off into just, well, I should have found my water early, how things function, delivering of a child is a EMT basic skill. The only time that you require a paramedic to be there is if there is complications at birth. Other than that, EMT basics are, that is in your scope of practice, and you can deliver a child just like everybody else can. When we talk about explosions and collisions, remember, due to the multitude of injuries that we're going to potentially see, hemopneumothorax, which means their lungs may have collapsed. There's blood inside the lungs. There's air in the pleural space. Penetrating injuries to the head, neck, and chest or abdomen. Those are vital parts of organs that are in those particular areas. That's why that's classified as a high priority or an unstable patient. Majority of the time, most time you go to somebody's house and you just pick them up for, shortness of breath. Those are going to be your unstable patients. But if you provide some oxygen and get them situated, they start to come down and get better. So that's not going to be in this category. All right, so the golden hour. Sorry, I keep getting all these messages. So a golden hour, or the golden period, is the time frame from injury to definitive care, which means if it's a wreck, from the time that it happens to the time that they get to the medical facility, not just because we arrive, but the time that they get to definitive care, during which treatment of shock and traumatic injuries must occur in order to maximize the patient's chance of survival. Immediately transport is if one of the keys to survival of a patient who need immediate care at the EMT level cannot provide. So remember, if that's something that you're unable to do, they only have a short window to receive that care before things start happening. Like a stroke, we have the golden hour. We have certain times to be able to, from the time the stroke starts to the time that they can receive that clot buster medication, can be up to so long. After that time, they don't get that. Here's a breakdown of the clock to kind of understand the difference in time. So let's say here, from the discovery of an incident to an activation of EMS, you have the platinum 10 minutes is the initial assessment, intervention, and packaging. So they're saying we only have 10 minutes once we get there to realize what's going on. We assess them, we do things to them, our interventions. Package, which means load them into the ambulance and begin transportation. So then you have 30 minutes to transport and initiate hospital stabilization. So within a 30-minute window, that's the only time you have to leave the patient's house and make it to the hospital before your golden hour is up. So it's not that long. I haven't gone yet until we started talking. It's not that long of a period, but knowing that you don't have that long to get the patient to definitive care, all your stuff starts shrinking. If they are an unstable and they start requiring higher level of treatment, that is one of those that it may be best to call for additional resources, as in a sprint truck and or potentially air medical transport. Those things are there for reasons. Here's what I was just going to say. So transport decisions could be made at this point. Transport decisions are based on patient's condition, the availability of advanced care, distance of transport, and your local protocols. For unstable patients, you must always do a load and go. Anybody that is stable, you can sit and play. Remember that. Those are the things that will save lives in the long run. So local protocols, always follow them. That is something that I can't just teach you what the national, I'm teaching you the national standard of care. Agencies can go higher, but they can't go lower. So if your agency is stating that they want you to do X, Y, and Z, then that's on the agency. You have to do what they say because you've agreed to follow the protocols. Most of the time, oh God, I had to get something to drink here shortly. Most of the time, your agencies, when they first hire you, go over your EMS protocols, explain to you the things that they are pushing through and that you must qualify or must certify to follow. History taken. Why, after seeing what y'all read there, why do I want to know about the history? What does it mean to me, and why do I care about their history? What do y'all think?
I believe the history tells you like how you're going to be able to properly treat that patient. You need to know if they have like just certain things going on that causes them to, you know, depending on like if you're going to administer some medication, if they're going to react to it or not, or you know, that good stuff.
Right. So it's allowing me to gain information that is pertinent to them. I wish it was something else. I promise you it's not. That's pertinent to them, that's going to help me treat them. If it is something that, like saying that they're a diabetic, well, I might need to know that as we move on, because sometimes they're sluggish of answering questions, or they're just overall general appearance may be like, well, I wonder what their sugar is, and it may be related. So as you can see, some of the demographic information that is important to us: age, gender, race, medical history, and current health status. I ask those simple questions for every single person that I take care of out here. They're very important to me because I know, like, if their parents have cardiac history, both parents have cardiac history, maybe I should run a 4-lead or a 12-lead and check this patient out. If their parents are diabetics, maybe I should check their sugar. They've never had any issues with it before, but it's that one time we just don't know about. All right, so investigate the chief complaint. I want you to figure out why that they called you and why is it so important that they called you now. Begin by making introductions, making the patient feel comfortable, obtain permission to treat them, ask a few simple questions, refer to the patient as Mr., Mrs., or Mrs., Mr., Miss, or Mrs. If I hate when I say that, using their last name. Again, we talked about that. Sometimes it may be offensive, depending on what part of the regional geographic you're from. But again, bedside manners opens up a lot and people start to respect you a lot. Open-ended questions will help determine the chief complaint. How long have you been hurting? Not like, so you say you've been hurting for just a few couple of days? Well, yeah. Or is it still hurting right there on your right side where we picked you up from last time? Can you show me again, Mr. Smith, where you're hurting at? Use eye contact to encourage the patient to continue speaking and repeat statements back to show that you understand. Mr. Smith, let me make sure that I have this written down. You state that you've been hurting on your right side after you eat for the last 3 days. It hurts when you sit still for too long, when you feel a deep, sharp pain on your right flank area. So what I'm trying to do is repeat back to them what they tell me to make sure I understood them. And it also, again, makes them feel like, hey, maybe he is listening to me. It gives me an idea of what they said and what I've said. And plus it's clarification when you go to write it down. Because I write a lot of things on my hand, on my gloves, as we're on calls to make sure that it's pertinent information to me. I try my best to go over a certain routine. I write their name, first and last, date of, and age and date of birth. And I don't need the address because it's something that I may have been dispatched to, or that's something I can just get later at the hospital. Medical facilities, when you take them there and you give a report, they're going to want the social security number and date of birth. I will only write the date of birth down. I will not ask the social security number unless we're standing at the counter for them to be checked in, and or it's something that I may not need just because they may be unresponsive. If you don't have any identification on them, they're going to probably put them in as a Jane Doe or a John Doe until that information is obtained. But having all the history that we just talked about, this is important. We want to know, and we're not done with the history, but little things help us build those up. So other people around there can help us. They may not know Mr. Smith. Family should know them if they're present. A person who may have witnessed what happened, just if they're able, they care enough to talk about it. Some people just don't want to get involved. Doesn't matter if it's their neighbor for 20 years, they just don't want to get involved. You have some bystanders that are willing to help. Medical jewelry or art. Be careful, medical alert jewelry. A lot of times I've seen it tattooed on some places. I have a friend of mine that has his tattooed on his neck. He's weird like that, but again, it's in good positioning for him. It's not something that we just don't know what it is. We know that he has that area there. Medical bracelets, I don't see them as much as we used to. But again, check people's phones, the ice that's stored in people's phone, medical alert situations. There's some information that sometimes we can get out of there, potentially like an emergency contact. That's something that's probably important to us. That maybe once they get there that we can ask some questions, and just asking the questions will build the information that we need from calling their medical alert person. And it just may be a phone number and speak to John. Okay, who's John? Well, John may be the next door neighbor for the last 30 years, and they just kind of have taken over kind of family of Mr. Smith. So those help. What's it say? Other patient medical history or documentation. Again, that's kind of why when I go and take care of elderly patients, I'll talk to them, but I go look in the refrigerator or on the refrigerator. Sometimes those things are just posted there. They're put on there with a magnet, and a lot of their medicines are kept in the refrigerator if they have to keep cold. And then just looking for medicine that may be able to tell you the first and last name. And it could be the medicine that tells you, oh, hey, I know this. This is for heart attacks, or they have some heart issues, irregular heart rhythm. That medication can help you. And then you'll be like, hey, are you Mr. Williams? And you're like, yeah, that's my name. And just because you just had a good enough idea to go and look. What's that say? All right, so let's break it down to another mnemonic. I love this mnemonic. OPQRS and T. This is probably the most important thing. Well, this is the most important thing in this chapter to me. We will cover a lot more of these importances, but to just ask these questions when you go through there. So we'll talk about O is the onset. What time did this happen? When did this happen? Does it provocation or palliation? Does that, what provokes it? What makes it better or worse? The quality, is it high, low? Is it good, bad pain or bad, bad pain? The region or radiating. Why I want to know if it's radiation is because is it going anywhere? If it's in my lower leg, but I can feel it all the way down to my ankle, okay, well, it's in my lower leg, but it's radiating into my ankle. The severity, I need you to give me a number. How bad does this hurt? And timing, about what time of day did this happen? Where did this pain start in? Identify any pertinent negatives. Pertinent negatives are negative findings that would warrant no care or intervention. If you go to a bicycle wreck, then you see lots of scrapes and bruises. Those abrasions are not really that important to treat because they're not going to cause life-threatening illnesses, but you need to note them. Several abrasions noted to the right leg, calf, and ankle from when patient was involved in the wreck of her bicycle. Be careful too when you document that it is a regular bicycle by pedals instead of just somebody that read it may consider it to be like a motorcycle. Those are some of the things you just want to be as descriptive as you can in your report. Any questions about OPQRST? I love OPQRST. Any questions at all? So we're going to talk about a sample. These are just mnemonics to help you remember things. OPQRST, SAMPLE, those help you remember how to ask questions, information to write down. So use the mnemonics sample to obtain the following information: signs and symptoms, allergies, medications, past medical history, last oral intake, and what events leading up to the injury or illness. Well, why do I want to know what they're allergic to? Well, I need to document that in my chart. Plus, I need to provide that information to the medical facility when I get there because wasn't finished. Because that's a very important information that I need to pass on. Because if for some odd reason that patient becomes unresponsive when they get to the medical facility, and we don't tell them that they're allergic to codeine or penicillin because we found out, and they give that medication, now that just caused harm to the patient. So those questions, again, are just as important as OPQRST. It helps you build on your patient, your patient care. It helps you build a background, dig information. These little mnemonics can help you just gather patient information on their history. All right. So critical thinking is the essential component in assessing a patient and involves gathering, seeking facts to help clinical decisions make a scene management, evaluation, consider what the information gathered means, and synthesizing is putting together the information that you have gathered and validated and synthesizing into a plan to manage the scene and or care for the patients. You might have, y'all get that or no? Is that question, y'all? We straight? Clear as mud? Y'all tell me.
Say that again.
All right. It's just reading what they said on the clinical thinking assessment. I'm just making sure that when we ask these questions that you're making good decisions, you're making good assessment techniques, building blocks as we continue this. Does anybody have any questions on that? So alcohol and drugs, why is that important to me? Why do I care if you've had alcohol tonight? Anybody? If you have, don't tell me. I'm gonna be jealous.
Um,
Alcohol thins the blood.
Right, alcohol thins the blood. Obviously, it helps make very bad, poor judgment. But we're not gonna create judgment. We're just gonna let them be like, all right, cool. Like I tell people all the time, man, I don't care if you snorted a pound of cocaine. I just need to know.
I have a question.
Answer.
And as this relates to, I guess, alcohol and drugs. So I guess how much alcohol in your system before it starts to initially thin the blood?
Can't answer that. I don't know.
Really?
Depends on if you're a habitual drinker or just randomly. It affects us all different.
Okay, I got you. I guess you're, in a sense, it's like you're, never mind.
And it depends on the size of the person. I'm a bigger guy than my wife, so it's gonna take more to potentially affect me because we have the same amount of blood, but I have more space for it to sit than it is anything else. So alcohol and drugs, signs may be confusion or hidden or disguised. You're probably gonna smell it if that's the case. Many patients may deny having problems. They're gonna try to hide it. They're going to say, I haven't been drinking. I don't know what you're talking about. I bet you only drank 2 also. Yes, I did. At some points, there's a line, but I enjoy drunks. I think they're great. Sometimes it's funny to me. The history gathering and chemical dependent patient may be unreliable, and do not judge the patient and be professional in your approach. I'm very honest to begin with too, so sometimes it's like, hey man, look how much you had to drink. Obviously way too much just to give me a number. I'm not disrespectful about it, but I'm honest. Let's not lie to them first off, but we know that we still have to be professional. We have to have a good bedside manner because we represent us and the agency that we work for. So it's like we just need to be cautious on what we do anytime we come across the alcohol and drugs. We see those in EMS a lot more than we're really used to because it's so easy to get nowadays. I mean, it's super easy. So those 2 things, alcohol and drugs, affect a lot of things in and around EMS. I'm not picky if people use them, but when you start affecting me, that's when it bothers me. I have my own approach against certain medications, if that's what you want to call it. But alcohol, it's drink but don't be drunken. That's kind of my thing. When you start making a butt out of yourself, it kind of shows the time to stop. Oh, why is it not working now? All right, physical abuse or violence. We have to report all physical abuse or domestic violence to the appropriate authorities. That is our job. I'm not going to say we took the oath to do that, but you are trying to help. You're an advocate for that patient. If your local protocol says something otherwise, follow it. Do not accuse, instead immediately involve law enforcement. It's not our job as EMS providers to reflect any type of personal decisions or anything that could affect the outcome. The best thing that you can do is involve law enforcement as soon as you recognize it. You realize, be like, wow, man, this lady has been beat up for a long time. She has different stages of bruising, different colors. Somebody step away and call for assistance. And you can tell the more aggressive ones versus the non-aggressive person that has caused them. And it could be a self injury person to where they injure themselves on how they deal with stress attention and all those things like that. So we don't want to just start accusing somebody. Matter of fact, a really good friend of mine's wife is epileptic. She had a seizure one time, slipped, tripped, and fell, bruised herself up, had stitches in her head and all that. And the two of them went to get some medication for her after leaving the hospital. Then this lady behind them came up to the wife and said, "Baby, you don't have to deal with this. You can come with me right now, and we can stop this." And both of them were like, "What are you talking about?" It affected the wife so bad she ended up breaking down and had another seizure while she was there because of the. And it's just like they automatically assumed, not knowing what's going on. But those assumptions can get us in a lot of trouble too at the same time. So be careful when we do that. It's just easier to get law enforcement involved and just document what we see. Sexual history. So consider all female patients. I want y'all to know this. This is important. If I could highlight this right now, I think I can, but I don't know how to highlight it. So I'm gonna figure this out because let's see, right here. Wherever I don't know how to do it. I don't know how to do this. Sorry. Anyway, doesn't matter. Y'all write that down. Sexual assault. Consider all female patients of childbearing age who report lower abdominal pain to be pregnant. Know that is something that is very, very important. If you expect any female to have that, potentially think of a pregnancy. Now, again, if you're asking a young lady, I mean, I've seen a 10-year-old be pregnant. So at some point in time, you're going to need to ask those questions, but it may not be best to ask those questions in front of a parent. I don't allow parents to ride in the ambulance with me unless it is a very small child that needs that extra comfort level. If it's something that I can buckle in a car seat and the child really has no idea or doesn't care for the mother or father to be back there, I ain't bringing them. You can meet me at the hospital. Ask that question. Hey, by any chance, I'm not judging, but are you potentially pregnant or sexually active? A lot of times they'll answer you, well, I mean, I don't know. There's your answer. Do ask the female patient about the last time their menstrual cycle was. I don't know how long they last. I don't care to know how long, but I have a feeling my wife and daughter are fixing to get on the same page, and I'm gonna move out. Just because my daughter's already dramatic, I can't imagine that. But that helps us potentially gauge how long it's been between the last cycle and or are they pregnant now at this point. So that's something we need to know about. Inquire about urinary symptoms with male patients. If potentially they start to have, it's more common for females to get UTIs, but again, males can. And they can also get kidney stones. That is something else we want to know about. I always ask my patients, hey, what color is your urine? I need to know if it's clear, light yellow, or dark. Those are important to me due to kidney functions. Is it potentially a pH balance problem, or is it a potassium problem? Those are some of the things I've just learned from being out here. When appropriate, ask the potential for sexually transmitted disease in all patients. Some patients don't know that they have been given or have a STD. I'm just roughly assuming that 20 of you in here may not know all the signs of an STD. It's something that you read it and you're like, wow, that was part of the symptoms. But again, learning those things as you go through there, and a lot of times patients with HIV or AIDS will go ahead and be like, hey, look, I just want to tell you something. I have HIV or AIDS. They're very forthcoming because a lot of the medical facilities that take care of them on a regular basis encourage them to tell EMS providers or tell physicians that take care of them. So that's something they hear from the get-go. So again, that may be one of those times that it's time to ask that, but don't let your emotions run your poker face when they answer you and they say, hey, I'm an HIV patient. You're like, you're what? That it's yes, it is something scary, but if you have your PPE on correctly, it's something that you can manage. I've taken care of multiple HIV and AIDS patients, and still to this day, I'm clean. So, I mean, I guess that's the best way to put it. It's okay, but just make sure you do it in a proper way. Special challenges in obtaining patient history. A lot of times when the patient just is like, they don't want to talk to you. Maybe they're hard of hearing. What if they're mute or deaf, or those things that approach that we know how to communicate with some people. Oh, I'm so sorry, y'all. Patience is extremely important when dealing with patients in their emergency crisis. Using a closed-ended question that requires a simple yes or no may work the best. Consider whether the silence is due is a clue to the patient's chief complaint. A lot of times, some of the patients I've dealt with in the past, when they're silent, they just don't like you. And I get that. Maybe they like my partner. If they start talking to my partner and I don't feel that it's one of those they're going to cause harm to them, I'll just let them sit there and talk to them. And as Rhea says, it's me every day in the hospital. Some people are just, I'm a people person because I love my job, but I don't like people. And I know people are like, what? I can talk to a tree when I want to. But sometimes people just would rather go around 18 miles instead of have to talk to one person. So I get that. I understand, but inform these patients. We need to be like, hey, listen, I completely understand that you may or may not want to speak to me. I just want to make sure that when I get you to the medical facility, I give the most important information I can and the most accurate information to the hospital. That's all I want to do. I don't want to carry on a conversation if you don't want to. Sometimes those people can open up, I'm not saying that they will, but they can, and provide you some information. Overly talkative, there's a lot of reasons. Excessive caffeine consumption, nervousness, ingestion of crack, cocaine, methamphetamines, or underlying physiological changes. Really about this most self-explanatory we can get. You can basically never talk yourself out of trouble, but you can always talk yourself into trouble. That's what I kind of always went by as when I was a deputy, is that you can always talk yourself into a lot of trouble, but it's very rare and hard to talk yourself out of trouble. So just being honest and asking those right questions from the get-go will help you out a lot. Again, we can see right there on the third bullet, just knowing if they potentially ate the crack cocaine or the methamphetamines, if they just ate it so they wouldn't get in trouble, I just need to know so we can get their stomach pumped. Because if not, you're going to die, Mr. Smith. That's all I want to do is help take care of you. So prioritize the patient's complaints as you would in triage. Start with the most serious and end with the least serious. If it's a life-threatening injury, we're going to treat that first. If it is a ABC issue, we're going to treat that. But know all the injuries. When they say, I'm hurting from this, and this, and you're like, oh God, those are chief complaints, but all of those need to be addressed in due time after we get through the life threats or the ABCs or CAB. That's something that we have to do. One is for report reasons. Two is to also make sure the patient knows that we start taking care of, that we really care about them, and just because that's our jobs. Anxiety, and consider the context of the situation and recognize that the observed anxiety may be signs of a serious underlying medical condition. Frequently, anxious patients can be observed in emergency scenes that involve a large number of patients, such as a disaster. Some anxious patients show signs of physiological shock, such as pallor, diaphoresis, shortness of breath, numbness to the hands and feet, dizziness or lightheadedness, loss of consciousness. Anxiety can be an early indicator of low blood sugars, shock, and hypoxemia or hypoxia. 64 degrees in here. Jesus. I just try to stay warm. So just because they're anxious doesn't mean that something's wrong. They may just be that type of person, but let's not just assume. We need to dive into that. If we start to notice, we see all these sweating coming around their face and all that, let's ask them, are you having any chest pain? Are you suffering from any heartburn, indigestion, upset stomach, diarrhea? No, we're not trying to give them Pepto, but let's ask those particular questions. It's something that we want to know that we can help fix. We can fix all those on your screen if we know the right questions to ask and we're able to build past that anxiety. Sometimes that you're not able to, we just have to go with what we see and treat them the best way we can. Anger and hostility, be very cautious. Remember who's the most important person on the scene. Might want to take a guess?
You.
I know, I appreciate it. Thank you all. I want y'all to know I'm really appreciative of that answer.
Oh,
Yourself is. You are the most important person on there. So if you woke up and you're like, whoa, it's a little hostile, take your time to take a step back and be like, hey guys, talk to them from a distance. What can I do to help you? Friends or family or bystanders may direct their anger or rage towards you. Probably 3 years ago, I ran a very chilling call. It was an unresponsive child at a daycare. This young baby unfortunately did not make it. I did everything I could for him. I don't know the outcome. I was interviewed. I had court dates, kept getting passed on and passed on and passed on. Don't know the outcome of what, of course, case was, but I was the last one to touch the baby. I took him to the closest medical facility, like my protocols say. Emily wasn't happy at all. I was accused of causing further harm, and that was far from the case. Hospital was less than 5 minutes away. I had a tube and an IV already in this baby by the time we got there, and I had good equal lung sounds. But I got a lot of anger from the family at the medical facility. We had to get PD there to calm them in the hospital, and then once we were leaving, the father and the grandfather both tried to attack me in the ER bay or in the ambulance bay. So the scene was safe because of where it was at, but this local hospital just didn't have any security guards, it was just a small hospital. But you have to be cautious of that. You have to be ready. I spoke with the mother. I knew her, but she was obviously upset. She asked a lot of questions that I couldn't answer. She never got hostile, but you got to think about those things, and they can turn just like that. Loss of a loved one, loss of a child, all those things can be super sensitive that we have to be, our spider senses have to be ready to go on if we need to leave, or we just need to try to calm them down as we start stepping away. Intoxication, again, Sometimes these can be fun, but do not put an intoxicated patient in a position where he or she feels threatened and has no way out. The potential for violence and physical confrontation is high when a patient is intoxicated, and alcohol dulls a patient's senses. You may get those particular calls to where the patient will not cooperate with you, and you have to call your med control and advise them of the situation, what the patient has done or is doing for you to be there. And you may get those calls to where the doctor's like, yes, I want you to bring him in at all, anything you can do, I want you to bring him in. Because obviously they need medical treatment. Or PD is just like, all right, screw it, we're gonna wrestle, fight him, strap him to your stretcher. Okay, you weren't ready for that. And remember when you go to do this, that it takes one person per limb to take a patient down. So you're gonna need at least 6 because you got to take care of the head at the same time. So that's 5. And then a person to just go rope the whole rodeo that you're fisting to get in a fight with, because you want more as you can.
Question.
Yes.
Isn't it like professional crisis management technique, right?
Sometimes calming measures work. Sometimes just specifically and strategically verbal judo helps. But sometimes these intoxicated patients are just like, I'm not going, you're gonna make me. Oh, yeah, we can. But I'm gonna have my friends come help me. You may get those orders to where, hey, look, that's a PD matter. You're like, hey guys, I can't touch him. That's a per my doctor. Y'all want him to go to the hospital, y'all have to get him. And again, it's just a lot of things and how we relay it to med control, and be prepared to answer a lot of questions, and then get the doctor's names and all that stuff and get the particular orders. So it's not challenging dealing with intoxication, but sometimes it can be fun. All right, a patient who cries may be sad, is in pain, or emotionally overwhelmed. Remain calm and be patient, reassuring and confident, and make a soft voice. Maintain a soft voice. Just be compassionate. I don't really know how else to tell you on that one. We sometimes want just that shoulder. Sometimes we need the ear. During a disturbing time, or maybe the patient's issue that they're going through is life-threatening, that is the biggest thing in the world that has happened to them, and they feel like all I want to do is die. Maybe they want to talk to you. Just allowing that person to just let it go. Maybe you not be the one to be like, I don't want you to touch me, but I'll sit here and talk with you. You don't want to just be ugly and rude. We want to maintain that soft tone, the professional courtesy, and move forward from there. I'm trying to see why everything on my phone is going off at one time. All right. Depression that's our mental health crisis in America is that all-time worse than I've been around, because a lot of the federal funding has been cut for mental health crisis or mental health, and we lost a lot of hospital resources. A lot of treatment centers have gone in half or just went under completely. A lot of times so we can also, I like to resort, depression, everybody at some point has been through it. Maybe we've been able to get out of it. You've been depressed about things. Like honestly, like being depressed and sad because you're having to work a holiday and your family's at home. Those are some of the things that somebody may deal with. And a lot of these depression things that you see on your screen on bullet number 2 may just be more than this particular person can and will be able to handle. We see a lot of it when coming in the offshore world, when you have your younger men that come out that have been away from home, but not been like going away from the home. And then you're having to work holidays, your birthdays, and you just can't get in your truck and go home after hours. You're here. I have a very good shift that I work with, or a team. We're all family here. We know everybody's wives' names, kids' names. We see each other all the time, and it's easy to pick up on those things when we're used to seeing this person. Like doing this 21-day hitch has been very, very stressful for a lot of us. I had 2 more COVID patients active today. I had 25 close contacts from them, so that totaled 88 people I COVID tested this morning. That's a lot. I've COVID tested almost 700 people in 18 days. I'm done with it. I'm not depressed. I'm not like, oh my God, I can't handle it. It's just, I'm ready to go. So we all deal with depression. Some people are able to deal with it better than others. But the best thing is just be an effective listener. At the same time, reassure them. They're like, hey, Mr. Johnson, I want to make sure I understood what you just said, that you're depressed about blah, 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 blah. And allowing them to know that somebody is listening to them is a big benefit. We always say that we're here for our friends and family to call us if they need something, because they may be having a mental health crisis. But are you really ready for that? A lot of people are like, oh my God, John's calling again. He's all depressed because Suzanne's out of town. And you're just like, that may have been John's last chance actually calling for help because he committed suicide. We just have to be ready for those sometimes. That's also just as challenging. Consider behavior or a history. Conditions such as hypoxia, stroke, diabetes, trauma, medication use, and other drug uses could alter a patient's explanation of events. So let's say like a stroke, they just may not remember what happened. Their memory may not be there. Diabetes, maybe they are unable to tell you what's going on. Same thing as a traumatic. If they've taken too much medications, or they took an illicit drug, they just may be like, dude, like 3 days ago, I smoked that. It's still in your hand, bro. So just remember when you start talking to them that they can have these mind-altering drugs or something else is physically going wrong that has caused them to lapse, basically. You can have dementia, delirium, or Alzheimer's disease can also affect these. A friend of mine's dad is just passed away from, he was diagnosed with Alzheimer's, dementia, and he just didn't remember anybody. Was married to one lady for like 70 years. Didn't know who she was. Couldn't remember the kids' names, couldn't remember his names. It was very traumatic to see him go through that. Obviously, he was an older gentleman than me, but he was a good friend of mine. It's something that you're just like, wasn't ready for that either. So understanding how to try to gather patient information from these patients, again, may just be what I see around in the area. What do I see that is in arm's reach of this patient that can tell me more things about them? Because if they have diabetes, there's probably going to be sugar in the refrigerator, maybe some orange drinks or stuff like that that we can look for. If they've had a stroke, maybe they're going to be deficient on one side or the other, and you're going to look to the strong side. If their left arm is the strongest and the right arm's the weak and it's drooping, it's going to look to the left side of anything that they go and sit at or do, because that's the only functioning maybe arm that they have. All right. Limited ability to understand what's going on. So keep your questions simple and limit the use of medical terms. Be alert for partial answers and keep asking questions. In case of patients with severely limited conjunctive function, rely on the presence of family, caregivers, and other friends to supply answers to your question. You may not have that. You may just have to be slow and listen to what they say. A lot of times you ask a question and their brain is processing it. And when they're ready to speak, it's sending the neurons to fire. And it's like, and then when you get the patient's like, oh, I'm ready to ask another question. And the patient's just not been able to say it. And then you ask another question and they stop. We have to give them enough time to potentially process this and move forward to answer those questions. Again, rely on the presence of family in a situation like this. You may have care providers in the medical facility. And remember, I despise hearing that's not my patient, I don't know. That's not an answer that can be tolerated in my book. If you're in here, then that's something you should be dealing with as your answer. Oh, get it, girl, I hear you. There we go. So again, asking the right questions and trying to gain the perfect information is the best thing that we can do for them. Cultural challenges: do not use medical language. Patients from some cultures may prefer to speak only with healthcare providers of the same gender, gain the assistance of the patient's friends or family members, and enlist the help of a healthcare provider of the same culture or background if possible. There are several religious entities, I guess I don't know if I want to call it that, it may not be the right thing. Several religious beliefs, geographical locations that may not speak to you, period. They don't want certain things done. Again, I try my best. I haven't done it in years, but if I work in an area for so long, I try to learn what the culture is in that area. If there's a lot of Latinos, I need to try my best to understand a little bit more of Spanish, or Hispanics the same way. Same thing in the Muslim religion. You have to understand certain parts of it to know what their medical outbreak are, or other Christian groups. Those are just the ones that I spend a lot of time in the Middle East, so I understand a little bit more of the Muslim religion than I do some of the others. But knowing how to work with those, maybe just being able to be bilingual, speaking sign language, that is a challenge that we have to face. And if it's a male trying to take care of a female and this cultural does not allow that, they're not going to let the female go with them. Then you get into that battle of med control says they got to go. It's a cultural thing. Probably not going to cross that battle between a medical director and a religious background. But be an advocate for that patient. That is a challenge. But again, that female, and specifically in some religions, that the female is not allowed to speak, to pass that information on, and their husbands may only speak for them, and that's all they can do. We talked about language barriers right briefly. Use an interpreter if possible. Do not determine whether the patient understands who you are. Keep questions straightforward and brief, and use hand gestures. Be aware of the language diversities in your community. I've said that before. If any one of you live in the state of Mississippi, you can call the University of Mississippi Med Center and speak into their MedCom. And at any point in time, they have a person on call that speaks at least every language, not a single person, but they have multiple people that speak at least every single language that's out there. It listed some different gesture, different travel. I doubt that, but they can help you get into contact with somebody that can speak that language. So some other states may have the same thing. I think Memphis, you can call the Med and they can do the same thing to help you. It's also called the MedCom for them. I think they're mirrored off of each other. I don't really know whose was first, doesn't really matter. But majority of your trauma, like your level 1 trauma centers, have that ability to. So if you can get a certain particular number for that med center that can help you with that, that will help your patient care dramatically and thinking about those language barriers. If you're unsure on what language, a lot of times I've done it before when I had a patient that was Portuguese. I didn't understand nothing. And I called them and they listened and got us in the right direction. And it was really, really, really helpful. Hearing problems, just because they're deaf or hearing impaired, doesn't mean we have to talk louder. I kind of laugh at that because I'm like, bruh, they're deaf. They're not have trouble reading their lips. You don't have to accent. So a lot of times just making eye contact with those patients and speaking to them and being the deaf part. Hearing impaired, use pen and paper. That's the easiest thing out there. It's just using that. If you know simple sign language, I don't know if it's AIS or whatever the other one is, try. I was with a guy in the Middle East that he was very, very fluent in sign language. Didn't really ever let nobody know until we were actually ASL. Thank you, Murray. I appreciate that. I was close though. That he was very fluent. We learned a lot of things from him. A lot of times we would use gestures like that in certain locations in the Middle East and we could get away with it. But pen and paper is the best when you start to have those hearing problems. Visual impairments, identify yourself verbally when entering the room. I've been told that they can tell that there's a presence there. Obviously they can, some of them, the visually impaired can see change of light versus when it gets dull versus right now. Like if it's right now, it's clear and I put my hand over this dark, they can tell the difference in that. Their other senses are higher. Their hearing, their taste, and their touch are that much more. I saw a thing on TikTok where this guy he's been blind for years. He did have some vision when he was born, but he's a woodworker and made some of the gorgeous pieces of bowls I've ever seen in my life and cutting boards. And I'm like, I would lose every finger I have, but he's a very independent guy. If you have to move anything when you go through there, please try to move it back. Like Braille, anything that has those Braille that may be in certain places that will help them speak. Make sure you either take that with you or make sure if you move it, put it back in a better location. I've seen some devices speak for patients that are hearing and visually impaired. They can run their hands over it and touch certain things that make it say certain words. Maybe autistic children can use those things at the same time and help them get their expressions through. Let's see. All right, so we've done our first primary assessment. Our primary assessment starts when? When do we have our primary assessment started? Let's back that up so we don't go further. Somebody want to guess?
When you walk inside of a home.
We start building an impression. What's going on? We see these things. We're going to start getting ideas that this or that, potentially this, or what about that? You're building all these different ideas. It's the same thing we do when we meet somebody new. We're like, hey, how are you? We judge them. We form an impression about that person by the way that they present themselves. Y'all can say that y'all don't do it, but I'm gonna call each one of y'all a lie. I promise you, we all judge people in some form or fashion, good ways or bad ways. You're building that judgment against that person. You're gaining a history on them. It is important that you, well, sorry, all right. So I lost my train of thought. So we've already got our primary assessment. We know that we're going to get vitals. We're going to do an assessment from head to toe, figure out what's going on. Ask them, Rodney types in, when you first meet the patient, when you introduce yourselves, we're going to assess their ABCs when we introduce themselves. And if they respond back to us, they tell us what's wrong. They give us a history. They do the OPQRST and the sample. Somebody tell me what OPQRST and sample means, and then we'll move forward. I'm waiting. Who's the first customer?
Sample is signs and symptoms, allergies, medications, past medical history.
job.
Their last oral intake and events leading up to the present injury.
And OPQRST is onset, provocation, quality, radiation, and time.
Appreciate y'all. That's perfect. I like to make sure that y'all are still paying attention. That's why I ask questions. Maybe sometimes I get tired of talking to you.
No, we just
So
gotta
we're
flip
at-
back. We gotta flip pages back to get to it. So give us a second.
Check those notes. Check those notes. I just want to make sure that y'all are grasping it too. That kind of helps me judge the way that y'all grasp those things. But we ask those questions in general, like, so I can gather this, I can gather that. I just want the same thing when I first meet you. We start asking questions, we start talking, shake hands. How big of a grip is it? It's the same thing, but we lead the conversation because we need information from you. So I'm not gonna be like, okay, so what's the onset? What's the problem? Anything you do makes it worse. Quality, I can ask those questions and just general questions. Hey, Mr. Johnson, how long have you been hurting like that? Wow, you've been hurting like that for like, what'd you say, 3 days? Man, well, tell me how bad the pain is. Like, can you get up and move? No, not really. Okay, well, on a scale of 1 to 10, 10 being the worst pain you ever had in your life, how bad would you rate that pain? Wow, you rate that pain a 7 and you've had that for 3 days? Oh, it hasn't been hurting that bad as a 7 for all 3 days, but it just got like that today. So see, I just asked those questions and he responded to me, and I was able to ask more that built a better history. And then he thinks that I'm paying attention, but I'm really just trying to lead the conversation to get what I want out of it. Because that's gonna allow me now to do a better assessment and to help potentially treat his pain of a 7 in his abdomen. So once you start listening to other patients, providers, ask questions, how they do it, you will build your own way. For the ones that are already in the fire service or EMS agencies, you may have experience doing this, but now that you're learning things like, oh yeah, I need to ask that one. I do this, this, and this. It helps. Same thing when we write reports. All that information that we asked, got to have everything on your chart has to be filled out. So if I memorize how my chart is, I can help memorize some of the questions that I want to ask. For any patient that we come across, it's going to be the same thing. I just want some questions. Let's do these 4 slides and we'll take a break. I think we've been going well over an hour by now. All right, so the secondary assessment. If the patient is stable and has an isolated complaint, you may choose to perform the secondary assessment at the scene. If the secondary assessment is not performed at the scene, it is performed in the back of your ambulance while you're en route to the hospital. However, there will be situations where you may not have time to perform the secondary assessment due to they're still treating your primary findings, the rapid transport, or you just not got time to get to it. And it's not a life threat, but it's still an injury. You may have to continue to manage life threats identified during the primary assessment en route to the hospital. The purpose is to perform a systematic physical examination of the patient. An assessment that focuses on a certain area or system of the body, often determined through the chief complaint, which is your focused assessment. So there's been many of calls that I've been to that I've never done a secondary assessment. I do have other vitals because my cardiac machine is doing it for me. I may just not know their pain scale, but that may not be something that's required. It's nice to have, but I just need to know those things. So let's say my patient has a broken right arm. It is a compound fracture, but on the left side, they have arterial blood squirting, and I can't get it to stop even after adding a tourniquet. Well, I'm going to put a tourniquet on, or maybe I don't have a secondary, and then I'm going to start applying direct pressure. Well, it requires me to stay on that arm to applying direct pressure for it to stop. Well, the hospital's 4 minutes down the road. I may not have any time to treat that other broken arm because I'm so focused on the life threat to fix that first. You may just not have time to do the secondary assessment, okay? That's what I wanted y'all to get out of that. All right, how and what to assess during a physical exam. I want to inspect, palpate, and auscultate everything on this patient. So look at the patient for abnormalities. Do I see any trauma injuries or traumatic injuries? Do I see any blood? Do I see anything that catches my eye? Do I see, do I hear equal breath sounds, lung movements? They're moving them down. I put when I literally, so understand how I'm gonna say this. I put my hands and palpate from the head to the toe, respectfully, and to identify any life-threatening injuries. You're not just gonna go palpate the pelvic area when there's no reason to do it, even though, oh, I'm just making sure I assess the body. No, that's called assault, and you're probably gonna go to jail. Same thing for the man or the woman. You can still go to jail if females palpate the wrong areas just because they're like, oh, I just gotta see it. And the same thing for men. We're just as guilty. But doing it in a healthcare setting, it needs to be done, and you can justify reasons why and document it. That's okay. But that's the reason why I want to touch everything from the hair follicles all the way down to their feet, because I got to document that. Maybe it was something small that you found, a stab wound underneath the right shoulder blade that was hidden by the bra strap. Well, if you wouldn't have moved it, you probably would have not found that knife blade. So making sure to do a thorough job is very, very important. Use the mnemonic decap BTLS. Another one I like. So somebody tell me what decap BTLS is. This is the good one. I haven't gone over it yet. Just see if y'all know it. Y'all doing some Googling. I know it. I can feel those buttons being Googled.
It's
Mnemonics
look.
for,
Oh,
for assessment in which each area of the body is evaluated for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, and swelling.
All right. So that's very correct. So it's deformities, contusions. I'm not sure y'all are probably writing this down. So I know she did a great job. I just want to go back over that. So deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. Did everybody get that? Thank you, Christine. I appreciate you doing that. And I think it was Miss Nikisha, and I saw Mary unmute. Appreciate all y'all wanting to dive into that. All right. Say BTLS again. So it is burns, tenderness, lacerations, and swelling. Okay. So make sure, because that's important. I want to make sure y'all get that. Okay. So you're going to compare the findings from one side of the body. Remember the different planes from the left and the right. It's the same thing on the front. It is the back. You decap BTLS every part you do, the head, the face, the chest, the abdomen, the arms, the pelvic, the legs, front and back of all of that. You check for all, and it's easy. You can, the way that I like to do it is I do like a negative sign, decap BTLS found from head to toe. Or if I find it, I write positive decap BTLS dash, Rodney, it is deformities, contusions, abrasions, and penetrations. So here, I'll show y'all on your screen.
I dropped something off in the, if y'all check in the Discord chat, I dropped a little something for everybody in the chat, make it easier.
All right, so I'm typing in the chat box this is kind of how I write my reports. If I find positive signs of decap BTLS. So I write a positive sign, decap BTLS equals C. So I found contusions to the right arm and I also found swelling to the right arm and dot, 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 dot. You can do that instead of having to be like, okay, for the face I had, da, da, da. You can write decap BTLS once and then list all your findings after that, because that's still covered under decap BTLS. And then you can move on to the next thing. Once you've covered everything, a lot of times you're like, did I do this? Well, the good thing about typing our reports is that we can go back and create space and start typing again. I remember we used to do the old handwritten parts. Oh my God. We had a lot of addendums added to it. You know, addendum 1 of 7. The longest one I ever wrote was like a 7-page report. So it was horrible. I should have just started all over after I wrote all 7 pages. So sample, OPQRST, decap BTLS. Those are 3 big mnemonics. I'm making sure y'all get it. 3 big mnemonics that we need to remember. Oh, come on. All right. Systemically assessing the patient is during the secondary assessment. The goal is to identify hidden injuries or identify causes that may not have been identified during the first 60 to 90 second exams during the primary or secondary assessment. In your books, if you'll look at skill drill 10-2, it kind of breaks it down for you, tells you what's going on, gives you some ideas. And remember, your initial assessment is going to take you 60 to 90 seconds. You're like, well, that's not a lot of time. Well, that may just be from you trying to do your primary assessment and then moving on. It's kind of like a triage. You're trying to do a quick triage to figure out what's going on. Be like, okay, you're a yellow. Well, am I right? You don't want to second guess yourself. Doing a methodical, hands-on approach, top to bottom, because we have a little bit longer to do our secondary assessment because we're trying to identify the hidden injuries. I'll tell you quick before we take a break, a friend of mine not too long ago worked a shooting. Boyfriend, girlfriend were in a fight. Gun was on the bed. One of them kicked the bed or jumped on the bed, gun fell off and it fired. I don't know what kind of gun it was. It struck the female. Well, they didn't know that it struck the female. She fell, no blood, no nothing, was unresponsive. Boyfriend called 911. Fire department got there, realized, oh my God, she's cardiac arrest. Worker got her, got a heart rate back, got everything situated. Couldn't find anything wrong with her. No idea, no reason why. Got her to the hospital. They were fixing to put a Foley catheter in her. And one of the nurses just happened to pick up when she grabbed her leg and tilted it up and back for the Foley to go in, obviously in the worst particular spot in the urethra. She was like, It's this little dot of blood. Come to find out, the bullet entered her right in the crease of her buttocks, traveled through through the small intestines, large intestines, and hit her in the liver. She lived. Don't know why she went into cardiac arrest, but she was in the hospital for like 3-4 months. Fire department went back to see her and all that. But it's like, how would you're not going to find those, and nobody's just going to be like, oh, you didn't find it, you're the reason. Hospital, the trauma team didn't find it either. Nurse was just in there to put a Foley in and was like, what is this? That was found. All right, so let's take a 10-minute break. We've been at it a little over an hour. We'll take a 10-minute break, and it is 7:15, so 7:25, we'll come back and knock out 39 more pages. All right, we'll see y'all in a few minutes. Sorry, guys, I can't remember what time I put us on break till. Oh, well. We'll continue to go. So now let's get to our focused assessment. Perform a focused assessment on patients who have sustained non-significant MOIs or on unresponsive medical patients. Typically, we base that off our chief complaint. It's the goals on a focused assessment is to focus your attention on the body's part or systems affected by the priorities. Once you realize that they don't have any life threats or major complaints or major issues, maybe we can say, okay, so they're pulling them from the car wreck and they're like, I'm okay, it's just my ribs hurt. And you do a full quick assessment, rapid assessment, and you're like, okay, well, maybe now we can focus specifically on those areas that are a complaint. We can work from there, work better to improve, make things a little bit better. And then we're like, okay, we can make things happen. Now I can focus on little bitty areas. All right, so the respiratory system. Expose the patient's chest, because if you can't see it, you can't treat it. Look again for signs of airway obstructions as well as trauma to the neck or chest. Gotta expose them. So and a lot of times we'll call them strip and flip. We cut their clothes off, flip them over to make sure everything's okay. That may be one of those that we have to turn around and be like, all right, we got to take all their clothes off and we can see what's going on. That's a traumatic situation that we do that. We're not going to do that for grandma that slipped, tripped, and fell in the nursing home. Listen carefully to breath sounds for nothing and note any abnormalities. So if you hear something, you're like, whoa, what was that? Like I noticed, abnormal breath sounds on the right side. Look for retractions in the chest. Look for increased work of breathing. If they're struggling to breathe, it's a little bit harder for them to breathe. Make sure when you assess their breathing, obtain the following information. We want the respiratory rate. We want what kind of rhythm it is. If you're not as all familiar, just be like, hey, notice that their respiratory rate's 22 times a minute. The rhythm is, labored and difficulty to breathe, quality of breathing, and their depth of breathing. Those are something that we can rate the respiratory system on and the adequacy of breathing, because depending upon that, they may or may not be able to breathe normal. And if we can fix those things with a little bit of work, the better off we'll be in the long run. We've talked about this before, but a normal rate in the average adult is 12 to 20 breaths a minute. Children breathe even faster. Count the number of breaths in 30-second periods and multiply by 2. So, 1 Mississippi, count them. Watch your watch for 30 seconds. When I'm on the ambulance, I change my watch to count in seconds also. When I'm not, I don't really worry about the seconds, but I only do it when I'm on the truck because I want to know exactly what the respiratory rate is. Hang on 1 second. Oh, sorry. I'm reading some messages I've been waiting on. So we want to know their regular, is it regular or irregular when we speak to the respiratory system? From the time to one's peak chest rise to the next should be fairly consistent. If it's not, we know that they're regulatively abnormal. If it's irregular, the respirations vary from the rate changes frequently. Their quality of breathing, their depth of breathing, all that will start to change when we get into irregular rhythms. I just had a complete brain fart. I don't know where I was going with that. But let's reiterate this. Respiratory rate, rhythm, quality of breath, and the depth of breath is important when we start to do the respiratory system. So quality of breathing, is it normal and it's silent like we all breathe? Do we hear any type of audible sounds, wheezing, high-pitched noises like a seal makes. Those are some of the things we want to note. Breathing accompanied by other sounds may indicate a significant respiratory problem. Do they have like a snoring sound when they breathe, like, and they're not trying to grunt when they do that? The high-pitched breathing out of their nose regularly could indicate that their respiratory system may be blocked. The depth of breathing. The amount of air the patient exchanges depends on the rate of the tidal volume. Remember a while back we went over tidal volume and how to get all that? You can almost always hear breath sounds better from the patient's back. Here's a picture. All right. So you hear he's checking on the chest. So you have your upper lobe, your lower lobe, and upper and lower. Remember which side of the lung has 3 lobes? Do y'all remember that? Come on, so I know somebody does.
Right side.
Good job, good job, good job. You like that? I was kind of like, just kind of give you a hint. Oh, go back, Chris. And then we're on the back side. We hear a lot better here because we don't have the pectoral muscles. We don't have all of that that's in our way. We get better breath sounds when we hear them from the back. Now, again, when you start to measuring right in here, you're going to have heart tones that you're going to hear also. So being able to differentiate between the heart tones and lung sounds are completely different sounds that you should hear, the versus the exchange of gases. It's a total, they sound completely different, but you got to know what you're looking for. If you're trying to palpate and auscultate, sorry, not palpate, you're trying to auscultate heart tones, you can go in the same area. I tell you that because I don't want you to be listening and be like, the right side don't sound like this, because you hear heart tones instead of lung sounds. So that's important to be able to differentiate. But same thing here, upper lobes and lower lobes, we're checking for breath sounds. You don't foresee have to have them remove their shirt, but you do want to take your stethoscope and go underneath, because any type of barrier creates a barrier of sound and an interference when you go to put your stethoscope on. Remember also to check here, like this one is missing a cover. Some of these particular stethoscopes, I was supposed to tell you the original name, but I just went completely blank. The signographers or something like that will make sure you need to have a diaphragm there. Some of them don't. You can hear better from a diaphragm, but that's just personal opinion. And they make these now for people that can't hear, like myself, to where you can listen to it and it amplifies the sound. It's really, really nice. I like those. Why is everything going off? Sorry. Everybody wants to talk on night of class. They don't want to talk to me on other nights. All right, so what are we listening for? I don't know. He just said listen to the heart tones or breath sounds. I don't know. Living for normal breath sounds, snoring breath sounds. The best way I can tell you to do this is YouTube breath sounds, normal breath sounds. You can Google all 5 of those right there, or actually all 6 of them. Normal breath sounds, snoring breath sounds, and play the video. Those are the best thing. Even when I was going through paramedic school and we were going through cardiology, I learned cardiology through YouTube videos. I learned the different heart tones through YouTube. It's a great tool. I highly encourage y'all to Google these sounds and listen to them. All it can do is help increase your knowledge. What questions do you guys have so far? Anything I need to touch back base before we keep moving on? Like saying like Bueller, you know, the old movie, kind of showed my time there. Sorry. All right, we'll keep moving. All right, so our cardiovascular system. That's when we start talking about our heart. We're gonna look for trauma in the chest and listen for breath sounds. We're gonna palpate, we're gonna touch, we're gonna make sure from the collarbone to the abdominal diaphragm area that everything's intact, from the shoulder to shoulder, from the diaphragm up, that everything's there. Start listening for those heart tones, start listening for those respiratory sounds. Consider the pulse and respiratory rate and the blood pressure at this point. Pay very particular attention to the rate, rhythm, and quality. That's something that we gotta do. That is our, you may not, even when we do this in our initial assessment, pay attention, even though it's gonna be super fast during this time, pay attention to the rate, rhythm, and quality, because if it changes at all during your assessment, you have a baseline to go back to, or maybe due to the epinephrine dump from whatever incident that you were at, that epi is carrying up by heart rates that's a lot higher. Their drive for breathing is going to be more, and it may start to decrease. But your initial one, you're like, bro, you're breathing like 25 times a minute. What are you doing? You can help slow them down, calming mechanisms. Maybe their rate, rhythm, and quality is starting to drop. Their heart rate's getting back to normal. So those are what we want to pay attention to. Consider your findings when assessing the skin. Remember, we went over that the other night. Check and compare distal pulses. Where are your distal pulses at, everyone? Tell me where we are.
Your feet, your wrists, your neck. Oh,
I just want to know where your distal pulses are.
oh, hold on.
I'll help you EMT out. Come on, y'all.
Is it the center?
Your distal pulses.
That's your wrist,
The
right?
left-
Your wrist is one of them.
The
Wrist,
left
yes.
vertical.
Your wrist and the artery around your neck. I just don't remember quite what it is around your neck.
So we're going to check for distal pulses. Even those are radial, they are distal and proximal and all that. Now remember, you're probably going to have differences between the right and the left. We need to note those changes. So if you check their pulse on the right, you check their pulse on the left. Note the differences, because there should be some kind of difference. You will notice a blood pressure change from when they're seated to their standing. If they have any type of syncope episode where they've passed out, you want to check both. You want to check when they're seated, and you want to check when they're standing. Consider auscultation of abnormal breath sounds. I want to know what they sound like. I need to listen to them, because now I have time to stay in play. Even if you don't, and this is a load and go, you still need to listen to these breath sounds. Still check for pulses in multiple places. You want to know if you have your radial and your brachial and your dorsal pulses. You want to know those things, because like I do all the time, if I check somebody's pulse in their feet, I'm putting an X on it. That way I know exactly where to go back to. And if for some odd reason I don't find a pulse in that later, I need to figure out what caused the change. What did it? Did something change when we moved them? Did they lose the pulse in that foot? Tell the receiving facility when you get there, I had a distal pulse. I'm unable to find it now. It's marked by a black, blue, red X on the skin. That gives them an idea, instead of being like, where the hell do you want me to start? I mean, if they have a pulse at all. So gives them that baseline of where to go. Here's our cardiovascular system we talked about. Y'all may want to make some notes on here of pulse rates. That will help y'all. I highly suggest y'all to know these. You will probably see them again
Chris, are you asleep?
I sleep. I wish.
Oh,
I was trying to answer a text message. I've been waiting from one of the team leads.
just
I
the way
really
you
wish-
paused, it just looked like you just the way you said what you said, and then you just dropped. It's like, okay, he's asleep now.
If I could, I promise you, 4 o'clock every morning making, I was up at 4, whatever time it'll be, probably 9:30, 10 o'clock before I go to bed tonight. It's just like, all right, so those will help you as we move on, making good judgments. And then there's a baseline that we can move forward. So now we know what the pulse rate ranges should be, okay? All right, so our pulse quality. I want to know what a normal pulse is. So everybody take the time, feel your pulse. Is it weak and thready or is it bounding? Y'all can just write in the chat box if y'all want to what your pulse is. Is it just, does it feel normal to you? And it's in this range? Or does it feel weak and very like it's thready, as in it's like it's almost not there? I can feel it. Those will tell you your baselines too. And just doing an assessment on somebody in your household, it's the best way to understand. Like this, the other night when Rob went over that sheet, the patient assessment sheet, doing that patient assessment on children in the house, another adult, and making sure, and another person saying, okay, that you did this, 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 in this order. That is the best way that you can learn. Even when you get to the boot camp, you're already starting to be prepared. I'm like, wow, bro, I got this down. How'd you get it so fast? I made my kids be still and lay on the ground, and my partner checked me off on that. Okay, right on, bro. Or either make your partner be the patient, and they're laying on the ground holding the sheet like this. Yes. So that, I promise you, it's works. Fire department guys, it's just do it to them at the station. Make sure your partners, you know, everybody's looking for those training hours, and that will help you in the fire service. So your pulse rhythm, it is regular. The interval between each contraction should be the same. The pulse should occur at a consistent, regular rhythm. If the heart periodically has an early or late beat, if a pulse is missed, so you can have a change of pulse. AFib is common. They can have an extra, there's a couple of guys out here that have extra P waves, which means they have an extra beat. It could be like doom, 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 doom. It could be irregular because that we know that it's there. It's just not on a regular. It doesn't happen every 8 beats. It could be 4 beats, 7 beats, 6 beats. It's irregular, or it's regularly irregular. That's okay. We know that. But again, we need to know that when we feel their pulse and you're like, did I just feel that extra beat, or did it feel like I went do-do-do-do? Note that. Continue to check them. I like to hold people's hands and check their pulse for a couple of minutes. That's allowing me, I'll quit counting after my first pulse rate, but that's allowing me to feel the heart in a process as the patient could be potentially calm, as they're relaxed, just sitting there talking to me. And I give that comfort measure when I'm sitting there holding their hand at the same time. And I'm kind of, you know, I just do the comfort measure. If I'm holding my hand like this, I'm like, listen, baby, it's going to be okay. We're going to take care of you. What is something I can do to help you? My name is, when you reach up and hold them, hey guys, my name is Wally. I'm going to be taking care of you tonight. I'm going to check your pulse real quick, but we're going to make sure tonight it's going to be okay. Remember, we all come in traumatic situations. We never get to come for birthday parties. Blood pressure. Pressure of circulating blood against the walls of the arteries. I would make sure that you know this. Make sure you know what the systolic and diastolic blood pressure is. And I'm pretty sure we're going to cover it in a second, so y'all get ready. So a drop in pressure may indicate a couple of things. So you may have a loss of blood fluid. You may have a loss of vascular tone and sufficient arterial construction, or a cardiac, you just got a pump problem. Maybe their pump is woe out, and hope to God we have a lifetime warranty on them. But sometimes people need to change their lifetime warranties out. Heart replacement, heart valve, you know, all these different things that they have done to the heart. Maybe they got a blockage. They need to go in there and rotor root the heart around. So those things happen, but now you know why the blood pressure's issues there. Myself, I'm on blood pressure medicine because I have the thickening of the blood. Truly, it's been documented that did not happen to me at all prior to getting COVID, December of 2020. Didn't have it at all. Never had any issues until now. My blood pressure's thick. My blood pressure's high because my blood's thick. Has a hard time moving it. I donate blood every 6 weeks. Not this time because I actually just missed it on the 26th, but those things happen. I don't have a cardiac pumping problem. I have a blood pressure problem. So the decreased blood pressure is a late sign of shock. Abnormally high blood pressure may result in a rupture or other critical damage in the arterial system. You will know a rapid change when there is a rapid loss of blood pressure. I mean, a rapid loss of blood. Blood's going somewhere. The heart is not able to pump it because now the viscosity is getting lower. Well, the quantity is not there. I'm pumping nothing in the heart, so the blood's not going round and round. It's going in and out, or it's actually going out. We have to stop that to maintain a level. A balloon or a bucket will always leak water as long as there's a hole in it. You plug the hole, the water will fill up. It's the same thing with your heart. And if you have a hole in your, let's say a hole through my arm and there's an artery, I got to stop the artery so my blood pressure can build back up. Now, it's not something that's going to be instantaneously, but we know why there's a rapid drop in the blood pressure. Blood pressure cuff with gauge contains of the following. To not also know what the blood pressure's name is. It is a sigmometer. Let me just type that because my spelling is not, my pronunciation. Yes. There's the proper spelling of it. So a blood pressure contains a wide outer cuff, an inflatable wide bladder, a ball pump with one-way valve, and a pressure gauge. Because I got to know how high I'm pumping this bladder up. At least we've all seen a blood pressure one time when you've been to the doctor's office. It may be a manual cuff and it may be an automatic cuff. Here's a picture of one that we use pretty regular in the field. That is a manual cuff with the blood pressure. Here is your gauge right in here. So this outer covering right here, the black portion, is the protection. There's a bladder on the inside. There's a line. Oh, I don't know if you can see that. So did y'all see when I'm moving over here, or is you only seen on this side? Anyway, we'll talk right here. Can you go back? I thought I went too fast. I'm sorry. Pastor Girl, if you just let me know when you're ready, and I'll try to slow down. I'm sorry, guys. So right here, there's some writing right here, and it says artery. So the artery runs on the inside of the arm, down on both sides, and you want to put the line right there on the artery. It velcros around. They do make small, medium, and large. They do make children's sizes too. Most of the time, we all carry the large and extra large. Ours on our monitor is blue and maroon. The maroons are they for big boys. We had to order one because we got some boys out here. So once you put it on there, your stethoscope goes right here underneath this line, against the skin underneath the cuff. And then you pump it up. You don't want to go all the way to 300. You want to pump it until you quit hearing the pulse rate, I mean, to the pounding sound of the pulse. You slowly start letting it off. There's a little valve on the hand pump that you start letting it off a little bit. And then when soon as you hear the pulse go thump, look at the number. That's the top number. When you let it go all the way down and you don't hear it anymore, that's the bottom number. All right, can somebody tell me which one is systolic and diastolic? I want to know which one's the upper and lower.
Diastolic is the top. Systolic is
Okay.
the bottom.
Who else was speaking? I'm sorry, I didn't look over.
I'm sorry.
No,
No,
no.
you're good. Lay's always first. It's fine.
I don't know if I'm right. I think diastolic is on the top. Systolic is on the bottom. No, I have that backwards. Crap. I don't know. I'm confusing myself now thinking about it.
Somebody else tell me. Y'all help you out. Nobody goes in this alone. We're a team.
Systolic is on the top and
No,
diastolic
I agree
bottom.
with you. No, I agree with the first one. Diastolic is the top, systolic is the bottom.
You're
No,
sure?
I think I was wrong on that. Systolic's the top and diastolic's the bottom.
Anybody else?
Systolic is the top and diastolic is the bottom.
See, we starting to become a team, folks. We're starting to become a team. We're gonna come up with an ambulance company name after a while. We're all gonna work for this company. All right. So systolic's on the top, diastolic's on the bottom. And I do this group conversation as one is to engage y'all, and two is to we all question things. I promise you, we all question things, and it gives us opportunity for us to talk amongst each other. So not picking on nobody. I really appreciate all y'all jumping in there, and that's great for me. All right, so look at here. So now our normal blood pressure, hypotension. So tell me what well, y'all see the answer. Jesus, Chris. So hypotension means low blood pressure. Hyper means high. Remember the words of the division? So hyper means high, hypo means low. Tension, blood pressure. All right. So here is normal ranges for blood pressures in adults all the way through neonates. Again, we're not going to be checking the blood pressure for, say, in a neonate to an infant. We just want to make sure the blood stays in the body, okay? We really don't want to start checking the blood pressure of anybody that's less than 7 years of age. I think it used to be actually 8, but from 7 on up, I like to say 8 because that's what I know of. And that's where we start going. But they still have the blood pressures for these all the way from neonates to adults. That's just why that they are where they are. So here's a little bit of background there. Oh, y'all probably want me to go back. I went too fast. Pastor Gula, sorry, I'm picking on you because I know I went too fast. Y'all let me know when y'all are good with that one. All right. Sorry, I was picking on you guys. I know y'all already know. All right. So the neurologic assessment, I want to know if you can comprehend what I'm saying. You read it, understand it, hear it, understand it, spit it back to me. But we are looking for changes in mental status, possible head injury, stupor, dizziness, or syncope. Syncope is 90% of the time what we go for is people had syncope episodes. Means that they passed out for some reason. People that are sitting and stand up and you're like, wow, feels like a boom. We get a lot of the elderly that go to the restroom and they vagal out, which means they're sitting on the toilet and they're like, and they push too hard and the heart's like, it didn't have nothing to give and they just pass out. Majority of the time they pass out and lean forward. Once they relax and calm down, they do use the restroom on themselves and you're like, oh God, why did I get this call? But that's our jobs. We try to keep them in the best mental spirits as we get there. Change in mental status is confusion. I'm unable, maybe I'm unable to speak properly, maybe due to a clot, could be a stroke. Some of those things are going to affect the neurological system and cause the neurological deficiencies. Whew. Evaluate level of consciousness. We talked about the AFPU scale. Now let's talk about the GCS, which is the glaucoma scale. The score can be helpful for providing additional information on patients with a mental status change. Now, I know is when we move forward, I will have a whole chart system on the GCS. I want y'all to know that, because when we start moving forward, this understanding why we're getting the GCS will help you out a lot in your patient assessment, because the highest that you can get is a 15, the lowest you can get is 3. So if you're dead, you still get a 3. So just knowing, y'all will need to know the GCS scale and how to particularly get these numbers. So if you guys want and start to try to move forward in things, go ahead and look up, Google what the GCS scale is and how it's used, because when I get into further discussions and chapters, we're going to talk more about it in depth. But at least if you have an idea of what it is, you may not know how to grade somebody, but at least knowing what it is going to help you out. Okay, so now we're going to look at your eyes. You know, eyes, to me, I've always said eyes are passages to the soul. You make a deep impression when I look at you, so I try my best to look at y'all. I'm not trying to look into your soul, but we want to know the eyes too. We want to do an assessment on them too. It's very important that we look at these, because this can tell us multiple different things. Normal eyes are round and approximately equal in size, and adjust their size depending on the available light. So the more light I have, the smaller my eyes are going to be, because they're sensitive. Some people don't have to wear glasses like outside at all. It's okay. I have to wear dark glasses. My eyes hurt. I have actually tried to turn out some of the lights in here, but it's against the policy for us to have lights that's not working. So a lot of times I will turn my big light out and turn on my little LED bar over there, because it's just so bright in here. The diameter and reactivity to light of the patient's pupus can reflect the status of the brain perfusion, oxygenation, and condition. In the absence of light, the pupus will become fully relaxed and dilated. So when you go to the eye doctor and they dilate your eyes, they want your eyes as big as they can get them. Well, we can barely see the color. We want the center part to be as bright as we can get it, and helps us see further into your cornea. So here's some pictures. You can see here on A, you have a constricted pupil. So this right here means that there's a lot of light in there. This one right here means they're dilated, so I can see as much into the cornea as I can. Now, somebody tell me, besides unequal pupils, what this potentially means right here. Anybody know? So remember, we're referring to the patient side. So what eye is dilated versus which is normal. So tell me what eye is dilated on this person.
The top, no, the second one dilated.
So we're looking at figure C right here.
Oh, the one on the right?
All right. Well, my right or your right?
My right.
All right. So my right, which is the patient's what?
Left.
Go off the patient's when we start talking about something. So patient's left eye was dilated. Now, what can this tell me when one is dilated and one is equal? What does that potentially tell me? Anybody want to guess?
You said when one is dilated and one is equal?
Correct. Look in your chat box, folks.
A
Yeah.
stroke.
TBI.
So we're going to lean towards a TBI. So we're going to have a brain injury. Now, I'm gonna throw you off a little bit more. So now we know it's a brain injury. What side of the brain is affected?
The left
Y'all
side.
all- Well, it's the right. So the right side of the brain controls the left side of the body. The left side of the brain controls the right side. So if you see a left pupil blown like this, that's dilated, you're going to have right-sided brain injury. That makes sense? Probably clear as mud. Did I just lose y'all on that one? So if your right side arm is having deficiencies, you have a left side brain injury. Does that make sense? I tried to break
It
down
makes
a little bit.
sense.
Okay. All right. All right. So the pupils, a small number of population exists with unequal pupils. That is common. They're very small numbers. Some cause of depressed brain functions, injury to the brain, trauma, stroke, brain tumor, inadequate oxygen perfusion, drugs, or toxins. A lot of times on some of your drugs, you'll see the big old pupils and they're just so attentive to things around, they may not know what's going on, but their pupils are very big. That's a telltale sign for law enforcement too. When you're looking at somebody and all you can see is pupils, not the white part of the eye, but you can see the cornea and all that is super big. That's an idea. So brain tumor, trauma, stroke, and injury to the brain stems in the back of the neck, all those can cause pupils to both be dilated or one constricted and one blown. That's not uncommon in those injuries. So when you assess the pupils, look for it. Here's a way that you can remember that. So another mnemonic. So they're called Pearl. Pupils equal and round, regular in size and reactant to light. I would remember that. So we want to know the Pearl, Pearl, the Pearl. Pupils equal and round and reactant to light. Regular in size, reactant to light. So that is what we look for when we go to assess the eyes. If you can say, during assessment, no pearl was noted, or positive pearl, which means both pupils were equal, round, and reacted to light. You good. Or no findings on assessment, pearl was intact. You can write it in multiple different ways. I guarantee there could be 19 different ways to write a report in this class. We would all write something different, but get the same point across. Everybody got that wrote down? Get another minute before we move on. So now we're going to check our neurovascular status. So perform a hands-on assessment to determine the sensory motory response. Basically, I want to know, can you feel me? Can you feel me? All right, squeeze my fingers. Following, making sure that you have good equal neurological movements. Check for bilateral muscle strength and weakness. Squeeze my fingers, give them 2 fingers, let them squeeze them. They can't hurt you or break your fingers when you put them like that. They can still do the equal grip test. And we want to test for pain sensations and position and compare distal and proximal sensors and motor response on one side versus the other. I'm not going to try to cause pain, but I can take my pen if I'm assessing your feet and run them up the bottom of your foot. Majority of the people are going to jerk. Sensory's intact. Hey, do me a favor, push the gas. Pull off of the gas. Wiggle your toes. You don't really want them to move their legs up or down because that's potentially mess up with the spine. Same thing with the hands. Do me a favor, look at me, pull your hands back, push your hands down, and you go to the sides. Those are different ways that I can check the neurovascular. Same time is push against me. Same thing you get to do when you go to the doctor for checking your status on which way is able to work or not. There's another little skill drill 10-5, gives you an idea of different things that you can and can't do. Anatomic regions, I want to check, remember, head to toe, head, neck, and cervical spine. So when I roll you over, I'm going to check the back of your neck, and I'm going to take my fingers, this is the way I like to put them on each side of the spine, and I go all the way down. Hey, did any of that hurt? No. Before I roll you back, I want to run my hands down the left side of your back, the right side of your back. And I'm also looking for any type of blood or fluid. Don't know what other kind of fluids back there. Sometimes I may not want to know. But what I'm looking for is when I do this, once I lay them back, now I'm going to palpate the scalp and skull. I'm going to take my hands. Do I find any decap BTLS? Is everything in contact here? And what I like to ask my patients are, do me a favor. I want you to smile at me and put your teeth together. Do you feel like any of your teeth are missing? No, I don't. They understood simple directions. Patient's eyes, do me a favor, look to the right, left, up, down. Those are the ways you can check those. What color are the white part of the eyes? Assess the patient's cheekbones. When I go to here, I'm going to palpate this area. Most of us have the bones through here and they're puffy. So when you go to feel it, you're going to be all cute and all that. We don't want to do cheek squeezes. But check for the patient's ears and nose for fluid. So I always try my best to take some 4x4s and I rub in their ear as I'm assessing it. I'm gonna lay it to the side, rub it, lay it to the side. Why am I doing that? What am I looking for on that 4x4? I'm gonna pick on something.
Fluid or blood?
So yes, I am looking for any type of fluid. I want to know if there's potential blood in the ear, and I should be able to see that on a white 4x4, but I'm also checking for CSF, cerebral spinal fluid. Cerebral spinal fluid, yes, CSF. And then that way, what it's allowing me to do is, once I do that and I lay it down, so the way that I see that is on the 4x4, when it dries, it will look like a star. 6, 7, I don't know, but it's in the shape of a star. Now it's not going to be perfect and all that fun stuff, but the CSF fluid that comes out of the ears will dry on a 4x4 in of a sparkly kind of way. It's a fluid. It's neat when you first see it, but then you're like, oh God, that's a trauma patient. That's how we check that. The nose is not, I haven't seen it really come out of the nose as much as you do the ears. And it's going to look more, when you first see it, it's going to look like a watery type of fluid versus like, oh my God, that's CSF. Well, you don't know until you put it on the 4x4 and lay it to the side. Once you do that and you see it, you need to transport that 4x4 with the patient so it can be seen by the facility. Now, you also need to know what side of the ear it came on. They'll be able to find it. I promise you, these neurosurgeons will find it. But again, notify and be like, oh, that was from the right. It did not have any from the left. So when you check the upper maxilla area, you're going to be checking the jaw. That's why I get them to take and push their teeth together and show me their teeth, because they're checking the movement. I want to check the hinges. Put your finger back on the hinges. Do me a favor, open your jaw. You can feel the movement of the jaw in that hinge. I'm not going to open the patient's mouth nor stick any of my fingers in their mouth. I have 10 for a reason. That's what I was given, and I don't want to lose them by doing that. I allow the patient to do that for me. Do you have any unusual odors in the mouth? Maybe just some Colgate. But what I'm looking for is maybe like a fruity smell. Do you notice a fruity smell coming from the patient? Low sugar, I just went completely, low sugar can cause a fruity odor and present to you as an intoxicated subject. So that's the reason why that you're looking for that too, is that's another sign before you're able to check their finger and anything like that. When you assess them, you're looking for that fruity odor smell to be hypoglycemic. And if they are, then that's an easy fix. But again, if they're not and they are intoxicated, they do have the difference in smells, but that's something a lot of diabetics are taken in as intoxications and do die in the jail because of that reason. The chest, again, I want to put my hands on, I want to touch it. I want to make sure I don't find any decap BTLS. While I'm there, I'm going to assess respiratory rate, quality, rhythm, depth, doing all that. And I can do it at the same time as I'm assessing them. You can put your hand on there. How many times does your hand rise and fall? I need to know that. Look for any abnormal breathing sounds. Is my hand doing this? Maybe the patient's one side or the other is not inflating, but why? I want to ask why. Again, time, date, and year, you may be able to do it with their clothes on because it's raining or it's 14 degrees outside. But majority of the time, you're going to want to expose the chest. I want to see, because if I miss it and get to the facility and they look at it, I'm going to feel like crap because now I just did a crappy job in doing my assessment. Move down to the abdomen. You see how we're doing this: head, chest, abdomen. Then we're going to go to pelvic and extremities. We're all doing a focused exam at this point. So we went over this the other day and I talked about the different quadrants. So the abdomen is divided into those 4 quadrants. There it is right there on the screen. So you can see, palpate for tenderness, rigidity, and patient guarding. We know what guarding is because all of us before been like, oh, don't touch me there. I'm really sore. Oh, I'm really sore. But you're going to assess all 4 of these quadrants. If I'm saying I'm hurting right here, can y'all see I'm on the right upper quadrant? When I go to assess that, I don't want to start on the right side because now I'm going to make the entire abdomen hurt. I want to start on the left upper quadrant. Then I want to go down to the left lower quadrant, scoot over to the right lower quadrant, and then assess that painful area last. That makes sense. Anybody? Feel me?
Yes.
Right on. I'm gonna call on somebody. Pastor Gagula, did you get that written down? Okay, perfect. So again, now we're gonna move a little bit lower. We're going to our pelvic. Well, pelvic areas are really hard to see because it's a lot of bony structure and depends on what part of, you may be a thick old boy. No pun intended, I'm talking about myself. It's hard to see any obvious injuries. For a broken pelvis, it's really hard to see that without x-rays. Now, you may be able to tell the difference because one of the feet are gonna be off and shifted to the one side or the other. The difference is you'll have, like, here's our feet on normal. If the hip's broken, one will be off and turned. So then that's a telltale sign that there's probably a pelvic injury. Ask them, hey, by chance, do you have one leg that's shorter than the other? And they're like, yeah, my left leg is. Not tonight. But look for those obvious signs, the injuries, the bleeding, the deformities. The shortness of and rotation would be a deformity noted due to potential pelvic fracture. Extremities, again, decap BTLS and check, put your hands on, run from the shoulder all the way down. Any of this hurt? Tell me if this hurts. Oh, that's a little tender. Okay, look, do I see an abrasion? Okay, well, I got that down. Or do I see a laceration up and down the arm? Note those in your head. You're gonna have to write that down later. At the same time as I'm looking for PMS. So here's another little mnemonic. You check for PMS on all your extremities. So you would say PMS times 4, which is right here on your screen. Pulses, motory, and sensory. If I do not have the PMS in the right arm, I would put negative PMS to or to the right arm. But if I have it in all four, I'm doing positive PMS times 4, because I'm only checking the extremities for that. Because most of the time your chest is not going to have motor, and you have sensory here. You can push, pull, you can feel it. You know, you'll be able to check sensory throughout the rest of the body, but PMS, really what we're assessing is that just in the extremities. Okay, now we can move to the posterior part. Again, we're going to check the back from the head all the way down to the feet and the back side of the extremities for decap BTLS. Stand by. So that's what we want to check for. We're going to palpate the spine like I told y'all, from the neck to the pelvis. That's the reason why I put my hands at the top of the neck, my 2 fingers, and I run all the way down to the coccyx area. If I can try to get my fingers right below the waistline, a little bit lower to the top of the crack, that's where your pelvic ends, your spinal cord, not your pelvic. That's where you're going to check for the pelvis, all the way down and check for any tenderness. As you're going, you want to apply a light pressure. So if this is the spine, I want to take fingers on each side of the spine right here, and I want to push in a little bit, but I'm going to run my hands all the way down. Oh, that's tender right there. Okay, I like to mark that area with whatever kind of Sharpie that I have, and we're good to go. It just allows me to be able to note later on where patients said there was some tenderness at. So that covers all our anatomic regions. So again, decap BTLS from the top to the bottom, extremities, pelvic, chest, all of those are included. You do decap BTLS all the way down. Again, the notation comes later down the road, so you're going to have to remember all this when you get there and you're like, I don't remember. Sometimes you just don't. All right, moving on. Get a drink, I'm kind of tired now. All right, use appropriate monitoring devices. Every tool that we have on the ambulance is there to help us. The cardiac monitor, the AEDs, the oxygen delivery devices, the pulse ox, all those things are to help us treat patients and to get a better understanding what's wrong. All right, these devices should never be used to replace your comprehensive assessment of your patient. Put your hands on something. Like, I'm a visual touch type of person. I understand things better when I can touch it, look at it, take it apart, put it back apart, and I'm like, that makes sense to me. So don't lose those things. A good one-on-one hands-on assessment can never be replaced by tools. It allows you to see and fix things. Don't ever forget that. Always go with your patient, not your monitor. If the patient's like, I don't feel good, and you're like, oh, your heart rate's 98 times a minute, and you're breathing 18 times a minute. Yeah, you're fine. Go with what your patient says, not your monitor. So that's a pulse ox. If nobody's ever seen one, that's a portable pulse ox that's not attached. It's a standalone pulse oximeter that allows things to check the oxygen level in your body. Plus, so right here, this is your O2 level. So you have 93% oxygen in your body, and your pulse rate is currently 73 on this particular person. Most of the time, these work. This is a little spring right here that keeps it in, so it has open and close. As soon as you open it, stick it on a finger, it automatically comes on. You don't have to push the little white button. Measure, I just talked about that. Next, capnography. I don't want you to have to learn this. I don't want you to, just want you to know what it is. It quickly provides information on a patient's ventilation, circulation, and metabolism. We're just gonna keep going. So blood glucometer, that measures the level of glucose in the bloodstream. You know, we do that by the little finger prick. I'd rather get an IV than my finger prick. That's how weird I am. But that's important to us because it lets us know if they're hypo or hyper. You remember the difference? So that's why we want to know what the You hear the blood pressure, you hear the CBG or the blood sugar. When you check those, or even if a patient has one and they want to check it, let me see what you got. What number is that? Woo, 155. That's a little high. They're like, well, that's low for me. My normal is 400. That's really high. The highest majority of the machines in the field go, I've seen is 500. They don't go any higher than that. Most time they just say high after that, after 500. I've taken care of somebody that said high. Once we got to the hospital, they checked their sugar and it was like 1170. That's the highest I've ever remember seeing out and taking care of somebody. So here is a picture of your blood pressure, non-invasive blood pressure. We went over that a while ago, the different parts and pieces. So here's your gauge. Here's the little pressure release valve I was telling you about. You tighten it up to increase pressure inside the cuff, and you loosen it out and see the pressure drop. Right, they're both the same valve, and the pressure comes out of here. It lets you check the blood pressure for systolic and diastolic. So now we're going to do a reassessment. Got to get comfortable. All right, so perform a reassessment at a regular intervals during the assessment process. The purpose of reassessment is to identify and treat changes in the patient's condition. Repeat your primary assessment, reassess your vitals, and look for different trends. When you say trends, it's because you have different sets of vitals to go over. So at this time, the blood pressure was this. They're going to tell you maybe they got better or the patient status got worse. Now, during your reassessment, I'm probably going to speak over something that's later identified. If you did something to the patient, you need to recheck it to make sure it's still working during this phase. Because on your reassessment, we're going to start here and work our way back down. We're going to continue the circle. Continue the assessment cycle until we've made it to the medical facility. If you've had time to reassess them, you were a long ways out. Most of the time, I haven't ever really gotten to, in all my years, is doing a detailed reassessment. A lot of time it is my initial assessment, my treatment, my secondary assessment, and that's where we are. If you treat a life-threatening injury, when you go back to it, make sure in your reassessment phase that you look for that it's still doing what's the initial job for and the patient has had any issues after it. You reassess their chief complaint. Mr. Johnson, are you still hurting in your right arm? No, it's gotten a little bit better. Okay. Note that at, what is it, 2023, patient stated that pain had no, or patient's chief complaint of right arm pain is no longer. Has the unit already identified the problem gotten any better? Has it gotten any worse? And what is the nature of the newly identified problem? So if I notice now Mr. Johnson doesn't have any toes on his right foot. Hey, Mr. Johnson, does your right foot hurt by chance? No, why? Just asking. Making sure, can you wiggle your toes for me? And they're wiggling like 2 toes because the other ones are missing. Best I can say is note those changes that you found, or note those obvious injuries now. So recheck your interventions, like I just said. Check all interventions that you did. I want to reassess my ABCs on the constant. I want to make sure those. That's why I like to talk to people that I'm taking care of, because it gives me the time to make sure their ABCs, their airways breathing. If they're talking to me, their ABCs are continuing to work, and I can get some communication from them. Ensure adequacy of interventions and consider for a new intervention. A lot of times when I check somebody's sugar and it's a little low, well, I probably need to start an IV, give them some sugar. I'm not going to take the IV out once I get their sugar up, but I can reduce the level of normal saline that I give them. So if you say somebody's having trouble breathing and you give them oxygen and they don't like the non-rebreather over their face, well, maybe you can take it off and put the nasal cannula in their noses and be like, hey, Mr. Johnson, I'm gonna take this big one off and I'm gonna put some oxygen in your nose. Still gonna feel a little different at the beginning, but we're gonna get the overall achievement to help you stay breathing on the normal. We don't want you to have trouble breathing again. So what you're doing is still assessing and telling them, hey, I know you had trouble breathing. You're doing better now, but I'm still gonna take that off, put you on a little bit of oxygen at the same time. I want you to still talk to me though. Miss Johnson, you doing good? So something like that. You're reasserting that you're doing something and you're checking your treatment. Identify threats, identify and treat changes in the patient's condition. This is the time that we can start our documentation phase. You may have tape, have a lot of documentations there. Document, did your treatment to the right arm, did it improve? When you find an injury, I like to write it down. I always have tape on my walls and my ambulances. That means I can write on them with a Sharpie as I go. You know, right arm injury, positive L, positive S, positive C, and then I move down, and I can look at that and go back and reassess that as I'm moving down the road. Plus, it's a really good chance for me to have notes. If I have a really good partner and we're not going lights and sirens to the hospital, a lot of times I get my partner to keep a piece of tape on their leg and take notes as we're going down the road. I do by no means, if we're going lights and sirens, I would prefer them to just drive and have two hands on the wheel at all times. Knock, knock, knock. Know this right here. Reassess the patient. If they're unstable, you want to reassess them every 5 minutes. If they're stable, every 15 minutes. Okay? 5 minutes for unstable, 15 minutes for stable. Got it? Y'all have listened to me for almost 2 hours now. A little bit over 2 hours and 10 minutes. I'm tired. I know y'all are tired. This is 2 nights of patient assessment. Your test opens in an hour and a half. Out of 2 nights, you have 10 questions. What questions do y'all have for me to talk about 2 nights? For 2 nights.
Why we only got 10 questions? That means it's so intimidating.
I could have given you 100.
No.
Could have given. I just asked one simple question and you just blew it all out of proportion.
I'll go ahead and change your test. I'll give you 100 and let everybody else stick with the 10.
Because I'm fine with my 10 questions.
That
I'm
sounds like a
great.
good idea.
I'm great with my 10 questions. I'm just like, wow, are these, I guess my question is it gonna be intense or is it gonna be like straightforward to the point?
So I'll tell you how I make your test so y'all understand. So a lot of these questions that you're asked are based off of, or they are nationally registered questions, okay? So instead of sitting there and trying to come up with questions to ask y'all for each chapter, I'm lazy. I'll let them, I go into JB Learning, tell me how many questions I want, and I hit random. One is because I can't say, it tells me exactly where that question is and out of the book and on what page. So if there's issues and maybe I didn't cover something, I can go back and look, be like, yes, no, I didn't cover that. Let's exclude that question, but I need to recap that and answer that. So I limited it to 10 questions because 20 questions, 50 questions, that's a lot. I think there's like 300 questions in this chapter that's usable. Don't quote me for that, but this is the biggest one. And as you can see, why I divide this up in 2 nights, because it's a lot of information. If we would have covered this in 1 night, y'all would have hated me. I promise you, y'all would have hated me. So, any questions, concerns, questions about this chapter? So I want y'all to cover something. So y'all know we're on a new module. This is module 2. So module 2 going forward. Now, here's some of the things to tell y'all. You will not be able to go back to module 1 to do anything that y'all have missing. If y'all have a 0, it's closed. That module's done. Once we finish with module 2 and start module 3, can't go back to module 2. It's done. You need to make sure you stay on top of things and do your chapter test and mod test while we're in module 2. Okay? Remember, you get one redo the entire module. There's 3 chapters, 4 chapters, 3 chapters to this module. A lot. Then we change into module 3. So knowing that, be very cautious. Everything has to be done before we move into module 3. If you don't, and we have a class on Tuesday, Thursday night, and it's a new module, can't go back. Please stay on top of things. So you're done. Module 1 is closed. So I want to make sure y'all know that. That's moving, we're going forward. You ain't gonna be like, oh, well, I missed chapter 9. If it's closed, we're going into chapter 10. Guys, that's, I hate unlocking. I give y'all module 1 to kind of get y'all broken into, but that's what we got to do with time management. I know I give y'all 3 days. You have Thursday, Friday, Saturday, Sunday night at midnight. It's closed. It's done. We're moving into chapter 10. So I messaged you before module 1 closed and make sure couldn't take some confused when you before module 1 was closed and wasn't told to take down, so I'm confused. Shelby, let me have to go back and read my messages on you. I don't know. Have to read y'all. I'm a little overwhelmed with work in 21 days, so I will have to work. If it's something that I've discussed with you, I'll work it out. But module 1 is there, and just letting y'all know we're going forward. It's going to get a lot harder. Not by me, it's just nature of the beast. We're diving off into a lot more of being an EMT. That's something that we just gonna have to do. Andrea and Shelby, I will get you an answer by tomorrow for sure. So if I don't get it to tonight, my apologies, but I'll get you an answer by tomorrow. So here's what y'all want. Let me get ready to type this down in the box so y'all can have the class code, and then y'all are able to move forward. All right, everybody, there is your class code is @1782. They don't have any questions for me. Y'all have a good night. Good luck on your test. And Tuesday night, please make sure you're there. Rob will be stepping in Tuesday night, and we're gonna have a guest speaker on Tuesday night. So y'all are actually gonna want to be there. So yeah, don't worry about the chapter numbers. Just stick with what the test says. I promise you, it's messed up. So make sure y'all are in class Tuesday night. Y'all are gonna get some really important information that y'all need to be there for. All right, folks, good luck. Have a great weekend. Remember, Tuesday I travel home, so I'll be unreachable on Tuesday. Good luck to y'all. Have a good night.
Likewise.